morning. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine and Consultant Neurologist. Today I am going to discuss with you few MCQ based discussion on respiratory system, auscultation of lungs. This is mainly for the third sem MBBS students. So let us see the first case. Which of the following breath sound is typically heard over consolidation? The correct answer is bronchial breath sounds. As we know, the breath sounds are produced in the tracheobronchial tree, and as it is passing through the lungs, the alveolus filters the high pitch sounds, and that is why you are getting the vesicular breath sounds. In a patient with consolidation, what is happening that alveolus is replaced with solidified tissue, and pathological tissues like consolidation easily transmits the high pitch sounds. So the sound that is heard in the trachea bronchial tree is audible over the chest wall, and that is the reason you get bronchial breath sound. Hope you understood the mechanism of bronchial breath sound. Bronchial breath sounds are actually the sounds that are produced in the tracheobronchial tree, and once it is passing, once you auscultate over the lungs, the high pitched sounds are filtered off. By high pitch we mean frequency more than 400 Hz. This is by the definition of the American Thoracic Society, and less than 200 is called the low pitched. Now we go to the next question. A patient presents with high pitched polyphonic wheezing. What is the most likely diagnosis? Wheezes are characteristically seen when the bronchi are narrow. So they are continuous or uninterrupted musical sounds produced due to narrowing of the airways. And this narrowing can be due to mucosal edema, maybe due to mucosal edema, bronchospasm, or something that is obstructing the lumen. So that is the mechanism of the production. So in bronchial asthma, what is happening? The bronchi of differing diameters undergoes bronchospasm, and that leads on to the characteristic polyphonic wheezes. So polyphonic wheezes are seen in patients typically in bronchial asthma. It can occur in patients with COPD also. So the correct answer, the most correct answer will be asthma. Now we go to the next question. Which of the following is a characteristic auscultatory finding in interstitial lung disease? The characteristic auscultatory finding is velcro crackles. So the correct answer is end inspiratory velcro crackles. So interstitial lung disease produces this sort of. Okay. We go to the next question. In a patient with pleural effusion, which of the following breath sound finding is most likely? The correct answer is diminished or absent breath sounds. Let us look into what is the mechanism of production of decreased breath sounds in pleural effusion. So pleural effusion is collection of fluid in the pleural cavity. So fluid is a good conductor. So here is a collection of fluid in the pleural cavity. Fluid is a good conductor of sound, but the problem is the lung underlies that fluid gets collapsed, and because of that the sound is not getting transmitted. So patient with pleural effusion will have decreased movement Percussion notes are dull because it is fluid. Blood sounds are decreased, or you can say there is dullness with silence. So this one point you can remember, dullness with silence. Dullness means percussion notes are dull. Silence means everything is decreased. For example, the movements are decreased, expansion is decreased, breath sounds are decreased. But in some cases, patient above a small pleural effusion, sometimes you may get bronchial breath sounds. So it's not a common finding. So that you should remember. We go to the next question. Which of the following is characteristic of pulmonary edema on auscultation? The correct answer is late inspiratory crackles, and later you can get coarse crackles also. Pleural is wrong. Inspiratory wheezing. Sometimes wheezing can occur, so that is why the statement all the asthmatics will not wheeze and all the wheezes are not asthma. Acute pulmonary edema when there is mucosal edema. There is a peribronchial edema or the collection is there that leads on to narrowing of the bronchi, and that can lead on to wheezing. So remember, sometimes asthma can present with predominantly rhonchi rather than crepitation. That is why the statement all the wheezes are not asthma and all the asthmatics will not wheeze. What is mean all the asthmatics will not wheeze? If there is a severe bronchial asthma, the airflow is insufficient to produce sound. So that is why the statement all asthmatics will not wheeze. We see the next question. Which of the following condition is most likely to produce a pleural friction trap? The answer given is, correct answer is pulmonary embolism. How pulmonary embolism produces pleural rub? So pulmonary embolism means a part of lung goes, there's blood supply, there is a embolus, it produces infarction of the lungs. The surrounding pleura gets inflamed. So that is why this is the area of infarction, and the pleura gets inflamed, and this will lead on to pleural rub. So chest pain is also a presenting symptom of acute pulmonary embolism. Classically, it presents with a sudden onset of breathlessness. There will be tachycardia, you can get hypotension, and you can get chest pain, hemoptysis, etc. So now we go to the next question. Which finding is most suggestive of a large cavity in the lung? Cavity by definition or typically produces what is called a cavernous breath sound. So the correct answer, the most appropriate answer will be amphoric breath sound, because large cavity can produce, especially a large communicating cavity. Cavernous type of bronchial breathing also is partially correct, but the most appropriate answer will be amphoric breath sound. So what is meant by amphoric breath sound? Amphoric breath sound is a low pitched breath sound with high pitched overtones, as if you are blowing across the top of a bottle. The sound will be like this. So what are the causes of amphoric breath sound? One is a large cavity, second is a bronchopleural fistula. Sometimes in tension pneumothorax also you can get. So we will go for the next scale. What is the most characteristic auscultative finding in a patient with a severe COPD? So this is prolonged expiration with wheezing. That is the correct answer. So in chronic obstructive pulmonary disease, you get what is called a broncho-vesicular breath sound. So what is meant by broncho-vesicular breath sound? Broncho-vesicular breath sound means it has got some features of bronchial and some features of vesicular. So there is no gap between inspiration and expiration. So that is one point. It is a quality of the vesicular sound, but the expiratory portion is prolonged. and as called, that is a feature of a bronchial. So it is called a bronchovesicular. Sometimes it is called a this vesicular with prolonged expiration. Normal vesicular will be like this. The expiratory sound will be heard only during the initial 1/3 of expiration. Hope this point is clear. So in COPD you get a vesicular with the prolonged expiration and rhonchi. Now we go to the next question. A monophonic wheeze heard over a localized area suggests what condition? Correct answer is foreign body obstruction. So last time or in the previous question we have discussed about the polyphonic wheezing, which is seen in obstructive diseases like bronchial asthma. Monophonic wheezes means a fixed obstruction. For example, suppose there is a foreign body occupying this portion, you will be getting a single, or it is called a monophonic, and it is fixed because it is heard only on a particular region. In children it is characteristic of foreign body aspiration. In adults it may be due to a tumor arising from the bronchus. So it's an important point if you remember. Monophonic wheezes is characteristically seen in obstruction by a foreign body or a tumor. So today's last question. Which of the following is characteristic of bronchiectasis? Bronchiectasis produces coarse crackles that persist after coughing. So what is that by coarse? The crepitations are depending upon the nature. You divide into fine crepitations and coarse crepitations. Fine crepitations are produced due to the explosive reopening of the alveoli that is producing, so it is usually inspiratory. These coarse crepitations are due to are produced when air is passing through airways which are filled with fluid. Suppose there is some fluid here, fluid is present in the bronchus or bronchioles. What will happen during inspiration? There will be bubbling. During expiration also there will be bubbling. So coarse crepitations usually present during inspiratory phase and expiratory phase. Hope this distinction is clear to you. As I have mentioned, crepitations are basically due to explosive reopening of the closed alveoli, but it can occur also due to passage of air through fluid filled spaces. So in bronchiectasis means there is ectasia, there is a dilatation of the bronchus. So in such condition what happens, when the air is going inside, when you are taking inspiration, there will be crepitations, and also during expiration. So this is a coarse crepitation. So bronchiectasis classically produces or typically produces coarse crepitations. Hope this session was useful to you. Stay tuned for further questions and explanations. Thank you.